It sounds dramatic, but it's true. And here to talk about the World Health Organization's involvement and the US withdrawing from the World Health Organization is our friend Meg Doherty. She is the Director of Global HIV, Hepatitis and STI Programs from the WHO. Good to see you, Meg.
And I'm really glad to be with you this afternoon, Karl, and thank you very much for having WHO on your.
You have been a great friend of Plus Life's, and it's always a pleasure to connect with you. So let's dive straight in. It has been a few months now since Trump and the administration have pulled the US out of the WHO. We've seen freezes, we've seen cuts, we've seen a lot of confusion. Where do we stand as of today as it relates to the WHO's position on the global fight against HIV?
Well, what we would say right now is that we're still strongly supporting all of our countries and taking our mandate very seriously. And if you've been listening to any of the press briefings, the conversations, the media discussions that our DG is having, he's also very concerned. I mean, he is somebody, Dr. Tedros, who is a minister of health at the very start of PEPFAR in Ethiopia. And he knows how important it was that all of those investments have really led to saving so many millions of lives. So from a WHO perspective, we're strong. We're continuing to do our work. We're looking at how we can mitigate the effects of all these changes that are happening, how we can look internally at our own guidelines and processes and approaches to supporting countries to simplify our messages and to help countries who are working towards integration of HIV programming into primary health care and strengthening those services along the way. But we're not stopping any of our guideline processes. We're working on guidelines for lenacapavir long-acting injectable PrEP. And, we're taking our mandate of convening and providing norms and standards during this difficult time very seriously.
Yeah, well, we're grateful for that. Tell me, just what's the real damage here? As it stands today, and I know your director spoke about this at a press briefing the other day, but really, how many more HIV cases and deaths are we facing because of these current positions, realistically?
We know right now the situation is in flux. It's dynamic. There are several models out there. If we look at the modeling that has been done by UNAIDS, which looked at, I think, the 55 PEPFAR countries, it could lead up to nearly 9 million or 8.7 new million infections and 6 million new deaths by the 2030, 2029 over the next several years up until the end of reaching the SDGs. There will be other models that will be coming out that have both the medium and worst case scenario, and those modelos will be having those estimates out next week. So I would say the new infections could be much higher. So look out for that modeling that's coming out next week, and I think that would give an indication that we know there's going to be a big range. And if we don't have services coming back on board in the next several months, in the next years, it could be much larger than some of these models are estimating. But what we have seen to be able to mitigate this is that many countries are starting to step up and they're starting to invest in their own programs. Nigeria has started to invest in their HIV programming. South Africa has done the same. So I think we also have to say all of those modeling and estimates are to alert the world to what could be the worst case scenario if we do nothing and if we don't make any efforts to change and to advocate and to get either new donors, countries themselves, new partners to support these programs so that we don't lose all of the enormous gains that you know about, that the 20 years of PEPFAR, the 30, 40 years of work is invested in.
Well, to that point, I mean, how far does this set us back in the global HIV programs?
Well, I think, if you look at the reports that we had over the last several years at the AIDS conferences, et cetera, we were looking at 19 countries who had already reached their 95 targets. I think most of us felt that the results that we got on HIV treatment coverage, testing coverage, viral load suppression We're driving even the successes that we've seen in the SDG goals. And I think there was a real optimism that if we brought in the long-acting prevention, that injectable prevention, that we could start to see ourselves really attaining our 2030 targets, of seeing epidemic control come to Africa and to many other places in the world. So do I think that's out of reach? I think we have to push and be sure that we can ensure maintain those people who have access to treatment, that they have access to treatment for their lifetime, and not give up on the optimism and the hope that we can bring out the injectable PrEP, which I think should be an additional game changer to be able to reduce some of those new infections. So I haven't become too unoptimistic. I try to remain optimistic, but I do think we have to be watching this. And one thing I can say for sure, sitting in Geneva, we are so thankful for the work that civil society members are doing, people living with HIV, because I can see it clearly across WHO that the HIV community is raising the flag and helping us to prepare and to shift into a new way of action. And I think other programs are being just as effective, but perhaps they don't have the same strong civil society who's out there fighting for a right, that health, human health, and as a right. And I think the work that has been done from the civil society has been really effective, and at least getting the messages out there, but even, standing up and helping with making sure the waivers are understood, helping, advocating on the Hill so that there could be some changes in the future. So I'm impressed with the civil society and the community and how impressive they have been in terms of coalescing and convening.
Yeah, well, I mean, if there's one thing those of us living with HIV have had to do from day one, it is fight, and fight we will continue to do. Why should Americans care about the US pulling out of the WHO? A lot of people go, well, it's the World Health Organization, that's in their backyard. It doesn't really matter for us here. But why should folks in the United States care about the US pulling out of the WHO, especially when it comes to HIV prevention and treatment?
Well, to be honest, it's not so much about pulling out of the WHO. Right? Why should Americans care about public health? And WHO is one of the players in public health. And I think in terms of the work that I'm involved in, HIV, hepatitis, and STIs, and also, we can see that translates into a lot of different communicable diseases, and that the Americans and U.S. have always been a leader in this field. They've been leaders in research, leaders in PEPFAR, leaders in bringing innovations to parts of the world. And I think that piece is so important to maintain, because right now I think there's a risk that research may not be funded in the future around the work that has been so groundbreaking coming out of the United States on new treatments for HIV, but new treatments for many other diseases. Also, I think there's a sense that, that infections won't come into the United States. And we know that viruses, microbes really have no borders. So the work that WHO does is important for all nations. And so in many ways, we hope that Americans can see how important it is to their own health in the future. And certainly that's a message that we want to bring, that as Americans, we're proud to be working in WHO. There are many of us here, and we feel it's important to bring our training, our experience, our fight and love for saving lives and public health. And WHO is a great place to be able to do that work.
You touched on it briefly a moment ago, but how is and what is the rest of the world doing? You mentioned Nigeria there, but to really keep HIV programs running, if worst case scenario, there is no involvement from the US.
Well, what I understand right now, at least, the US is doing quite a bit currently, and I think we should be thankful that that still is happening, that their PEPFAR is still there, and has support, that their CDC is functioning under the waiver, and some of the USAID programs set come back. So we do know that there are some important elements that are continuing around those life-saving interventions. But I think also it's really been a wake-up call for, I think, the whole world and countries to say reliance on a single donor is not what we need to be doing. We need to always be diversifying the way we do our work and our resources. I think for countries who have a large HIV burden, they are also saying, okay, now is our time to really see how we can find the domestic finances and the other internal processes to be able to have a program that's fit for purpose for the country and the health system that they are running. So it's good to see how that transition is happening in different countries and greater ownership. I think from the very beginning of the response around HIV, it was an emergency fund. I think there was an idea that eventually there would be this more country-led, country-owned program that's sustainable on the country terms. And I think if you look at the Global Fund, they're still very active and they're supporting the ARVs and they're supporting the country programs. So in many ways, we are working towards a model that we were hoping to work towards, a sustainability model, a model where we're strengthening the health system, we're strengthening the primary health care, and that HIV is optimized and probably simple enough now to deliver in a primary health care service.
We're all for how can we find and make things more efficient, and I think most of us would agree with that. But there is a humane way of doing it, and it would seem certainly at the very base level that what the US has done here, or at least threatened to do in certain parts, is not very humane. And to the point that I had a conversation with a friend and colleague from Kenya last week in San Francisco. She's a great HIV activist, you know her, and she said, well, my meds run out in June. And I said, well, what happens after that? And she goes, I don't know. So there is the sort of the humanitarian side of it, right?
Yeah. It's hard for me to comment on that.
I understand.
But I can comment on, what are we seeing and hearing from community members? And to be honest, we were asked yesterday to join a community dialogue, a change webinar on something I never thought I would have to ask and be asked about, is how can we safely stop medicines? How can we safely reduce our doses of medicine or take them intermittently? And this is not something that anybody who's been involved in the HIV treatment or anybody living with HIV wants to do, because our guidelines would say, don't stop your medicines. These are life-saving. You should be on them for your life. And that we don't want viral load to go up. We don't want people to become sick. And also, we also are not always 100% sure if you take breaks, how that might bear over the future. Will there be drug resistance that develops, etc.? But I think we were asked practically, these are the questions that people are facing. Like if they can't get to the clinic, if the stocks may be available in the country but not at the clinic, what are they going to do? So I think we can start to answer some of those questions so that people, if they have to take a break, they can do it safely. They can know how long should a break be done, like stopping your medicines all at once, don't stop them intermittently, etc. And we've been asked to take on sort of a policy process to look at all the evidence around structured treatment interruptions. Can we do this safely? And what would be the parameters around that? So we're going to be doing that, and we're going to be looking at that evidence. I don't know if that's going to save so much funds over the long term, but it might give people some peace of mind if they have periods of time where they're not able to get their medicines, how to do this safely and get back onto treatment. The good thing is that the medicine that many people are taking with a dolutegravir, an integrase inhibitor, is pretty robust at this moment in time. But we want to save that because we definitely want that available for the the 10 more million people who need to access it, or more over the next 5 to 10 years.
Yeah.
So we feel for the stories that people are very anxious, and we'll try to give as much information as possible. But we're also looking at, and I think people are taking this very seriously, in Global Fund and even in PEPFAR and others, about what are the stocks looking like, and are there going to be other ways if funding is reduced? How do we preserve the antiretrovirals? How do we preserve antiretrovirals for pregnancy so that we have no children who are born with HIV? All of these issues are definitely on the minds and of the most essential services that we need to keep going. What WHO has done thus far is we sort of repurposed our guidance around essential health services to how to maintain them that we had in COVID. We repurposed that for this scenario, and we've been asked to even update it again, and we're in the process of doing that so that there's even a more clarity about prioritization. What are the must-have services, must-have interventions? What are those that are nice to have if a country is unable to finance all of the above? Yeah.
Yeah. So for all of us who are fighting to end HIV, Meg, what's your message? How do we stay in this fight? And how are you guys there at the WHO helping us stay on track?
Well, I think right now we're trying to be as optimistic as possible. And I think the one thing I could say, it should be my ending comment, but we've been here before in the HIV field. I started my career knowing about HIV, learning about HIV in the late 1980s, actually, in Zaire and RDC. So I think, we're kind of going back to the future, as one might say. Simplification, ensuring that we have great advocacy messages, and ensuring that we're fighting for the essentials. So for WHO, we're following data, and we're doing that with lots of other partners and triangulating the data of what's happening in countries. When countries are asking for TA, we're providing that. We're putting out guidance around how to mitigate, how to prioritize. We're working certainly also, if there are any reports of ARV disruptions, trying to help countries through that. I do have to say one thing now. ARV disruptions doesn't mean necessarily that a country has a stock out. And the DG mentioned 8 countries that had ARV disruptions, and that was interpreted as stock outs. There aren't stock outs right now, but they may be in the future. And if a country even has ARVs in the country, but they don't get to the person in the clinic, then it's essentially just as challenging. So we're going to keep our eye on this. We're going to work with countries, and we're looking at models within the primary health care to see how that is going to be able to provide quality health care. We're looking at all countries. It's not just sub-Saharan Africa, though we know that is the most impacted right now. And we're looking out for the populations who are getting left behind: children, pregnant women, key populations. One thing we did do, I didn't tell you about, but I think we realized early on people were dying because they weren't able to get methadone or buprenorphine. So we're putting out guidance and trying to work with countries to maintain those services, because we know those are some immediate impacts that we need to, with countries, with partners, ensure that we don't have unnecessary deaths because we haven't looked at some other solutions to be able to solve the problem out there. I think the other thing is, what are going to be the new partnerships that's being asked of us recently? And foundations are interested, philanthropies are interested, private sector is interested in, but no one group is stepping up and saying they're going to fill the gap of what financial gap we've seen right now. But I think with large, perhaps coming together, we'll be able to at least have some bridging until countries are in a position to own fully their programming, finance it, and identify those countries who need to continue to have more support for purchasing the commodities, etc. So we're in it. and we're trying our best, and just we will be launching guidelines as well, but realizing that we have to put that into the context of what's going to be able to be implemented, like long-acting AR prevention with lenacapavir. We're so excited about it. We don't feel like we can miss this opportunity. So I guess my final comment is I'm optimistic, and I want to ensure that we don't lose, that we don't become so worried about what's happening out here that we forget at the center of this, we're all in this work because we're here to save lives, and we've saved so many, and we have to continue doing that as we go forward.
Yeah, and as we say, the H in HIV stands for human, and I'm going to reach through the screen and grab some of your optimism. Meg Doherty from the World Health Organization, thank you so much for making the time. I know it's crazy for you guys at the moment, so we really, really appreciate your friendship and all the work you do.
Thank you. I appreciate that you come and reach out to us regularly. So
that is going to do it for this episode of Plus Talk. Hey, what did you think? Leave a comment below because we check them out and we're curious to hear what you think of our stuff. Remember, you can like, follow, and share. We are at Plus Life Media across all your favorite social platforms, and the website is pluslifemedia.com. Until next time, be nice to one another. We'll see you soon. Bye-bye.